Hello, my name is Meg Monday, and I'm the Director of Educational Programming at Cancer Connect. I want to thank you for joining us today for a live web chat with Dr. David Hyams on advances in treatment decision-making for patients with ductal carcinoma in situ. This program is part of a continuing series of updates on new advances in the diagnosis, treatment, and management of cancer, its symptoms, and the side effects of treatment. We are delighted to be able to bring you this two-way dialogue so that you can interact directly with world-renowned experts here in our community. We're very excited to have Dr. Hyams from Desert Surgical Oncology in Rancho Mirage, California, as today's expert. Dr. Hyams has over 25 years of experience in surgical oncology and has spent much of his career in academic medicine, serving on the faculty of two well-recognized universities. In addition to his surgical expertise, Dr. Hyams is an internationally recognized consultant and educator in surgical oncology. Needless to say, we are thrilled to have him speaking for us today. Today's program takes place in two parts. To begin, we'll hear from Dr. Hyams. During the program, you will have the opportunity to submit questions. Just type in your question in the space provided below on the screen. Then, after the presentation, Dr. Hyams will answer as many questions as possible in the time allotted. We appreciate your interest and participation. After the program is over, we'll host this program on our on-demand section here in the community so that you can visit it again or share it with others. Thank you again for joining us, and I will now turn the presentation over to Dr. Hyams.
Well, good afternoon. Today we're going to talk about duct carcinoma in situ. And duct carcinoma in situ is really a form of breast cancer that is truly a cancer, but in which the cancer is confined to the duct itself and has not grown through the wall of the duct. As you can see in the diagram on the slide below, the normal duct in the breast is a series of single cells that line a tubular structure, and over time these cells may increase in numbers and become more bizarre, and when they do, eventually they reach a point at which the normal cell appearance begins to look more like a cancer cell than just a different or atypical duct cell. When that happens, the name duct carcinoma is utilized, but because it's in situ or in place within the duct, that becomes duct carcinoma in situ. Now, for any cancer to actually present a threat to a patient's life, the cancer has to invade through the base or the scaffold, or what we call the basement membrane that the cell sits on, in order to invade and reach blood vessels and lymph channels to travel to other parts of the body. So in fact, when we speak of duct carcinoma in situ, we're speaking about a pre-invasive form of true breast cancer. Nowadays, this disease is diagnosed typically with screening mammography, and most commonly because of abnormal calcifications that grow in a characteristic pattern that looks like a tree branch. Most of the patients who have this disease are asymptomatic and never would know they had it had they not had a mammogram. Now, as it turns out, duct carcinoma in situ is a disease that is increasing dramatically and has increased from the 1970s to the 2000s, as you can see on the current slide, from about 1.87 per 100,000 women to 32.5 per 100,000 women. DCIS, as we'll abbreviate it, henceforth, is a disease that was really pretty rare. I mean, occasionally women in the 60s and 70s and 50s presented with a mass in their breast that was only non-invasive disease. And that does tell us something. It tells us that some DCIS will never evolve to more than that. But in fact, most DCIS before screening mammography was found only in association with invasive disease, because the DCIS that came to people's attention had in fact progressed to an invasive garden variety breast cancer, the kind of cancer that's at risk. If you look at the chart on the current slide, you can see how the incidence of invasive breast cancer has actually begun to fall off slightly as an incidence per 100,000 population, But over the same period that invasive disease has fallen off since about 2000, duct carcinoma in situ, while leveling somewhat, has actually increased. The growing incidence, unfortunately, of DCIS serves to highlight some poor understanding that we have relating to the disease itself and to its management. There are really a number of contradictions inherent in its treatment. I certainly recall in the 1980s when the first data came out showing that breast conservation or lumpectomy was a reasonable treatment for invasive cancer, that for nearly the rest of that decade, we continued to recommend mastectomy as the primary treatment for women with DCIS. There are more articles written today regarding controversy in treatment for DCIS than there are of invasive breast cancer. And yet, I think the important point to remember is because it is non-invasive, it has not grown through the basement membrane of the duct out into the surrounding tissue, it is in fact a non-fatal process. DCIS itself cannot kill you. In fact, overall, if you look at people who've been diagnosed with DCIS, the survival at 10 years is about 95%. Treatment is more aggressive in many cases in invasive breast cancer because of the biology of the disease. It often occurs as a more amorphous area of involvement rather than a tight, dense lesion. It may track along the ducts over a broader distance. That is called multifocality, when there are multiple foci that arise within a duct system, multiple focus points. And DCIS, more commonly than invasive disease, can occur as what is called multicentric disease, where we actually have different totally isolated cancers in the same breast that are still non-invasive and non-life-threatening. But I think what we need to remember is that while DCIS may evolve into invasive cancer, and that's one of our biggest concerns, not all DCIS evolves into invasive cancer, and there are autopsy studies that go back to the 1960s and 70s that show a much higher incidence of DCIS than the invasive disease we would expect to arise. It is a disease, nonetheless, that is very heterogeneous, and so you have some much more aggressive forms, and you have much more benign or indolent forms. Unfortunately, what we really want to do is make sure that we can rationalize the care of this disease so that we're not over-treating patients, but we are adequately treating. And first, what we need to recognize is that recurrence, not survival, is our treatment endpoint. Because DCIS, as I said before, isn't a threat to people's lives. Therefore, measuring survival as an endpoint would be extremely misleading. What we want to do is find ways in which we can optimally choose therapy. And right now, or at least up to the last year, our formulation of treatment protocols has largely been based on the appearance of DCIS and correlations with some large studies of how different diseases may behave based on their pathology appearance. The slide in front of you is an example of DCIS in a duct. You can see not a single layer, but that sort of blue series of dots within the circular duct is really thousands and thousands of cells that are multiple cells thick, and ultimately have at one point filled the entire central portion of a duct to the point that they outgrew their own blood supply and died in the center. That's called central necrosis, which means central death. This was considered to be a very poor prognostic sign for DCIS, again, not for survival, just in terms of recurrence. But the thing we need to think about today is what are the implications of the disease? How do we best manage it? What is the impact of treatment? What do we hope to gain? And why are we concerned with treating it at all if it's not a life risk threat? Finally, what we need to do is understand how we think about treatment of any given patient's DCIS with their overall risk of breast cancer, because in some cases we have to plug this into a whole process. Of course, the management of DCIS for the last 130 years, since it was described by Joseph Bloodgood at Johns Hopkins in the late 1800s, is surgery. it was, of course, traditionally the same as it was for invasive disease, that is a mastectomy. The only difference being that since DCIS cannot spread to lymph nodes if it is truly DCIS, in fact, instead of removing lymph nodes and breast tissue, only the breast tissue itself was removed, or what we call a total mastectomy or simple mastectomy. Without removing the lymph nodes, that's without an axillary dissection. And this approach has resulted in a cure rate of 98 to 99%. And when this is done, because the margin, theoretically, around any DCIS should be complete, no additional treatment to the affected breast has been or is required. Breast conserving surgery, however, is obviously more appealing to many, if not most women, because of the ability to conserve appearance. But there's, of course, a small price to be paid. There's a higher risk of cancer recurrence in women treated with conservation therapy or lumpectomy than women treated with mastectomy. Now, the recurrence rates, of course, appear to be related to the margin or the amount of normal tissue removed surrounding the cancer, as you would expect. If you just take out a portion of the DCIS and leave it behind, recurrence is likely a foregone conclusion. But what do we make of this? Well, firstly, if we're going to choose breast conservation surgery or lumpectomy, we typically want to do this for women who have small tumors, probably less than 2 or 3 centimeters, and tumors that are localized, not multicentric or even extensively multifocal. And we want to do this where we can get adequate margins. That is a clean area of removal around the primary tumor site. The margins don't necessarily have to be huge, but they do need to be clear, or at least certainly that should be our goal. Mastectomy is probably a better choice for women who have larger areas of involvement or where the breast is relatively small as a ratio of the cancer to the breast. And certainly in women who have multiple areas, that is multifocal or multicentric disease, and those women who are not able to consider the other add-on therapies or adjuvant therapies that we add to primary surgical treatment when we conserve the breast, such as radiation therapy. Of course, there are women who choose not to have radiation for a variety of reasons, and they're willing to accept increased risk, and that's every patient's choice, but we'll discuss a little bit about what that means and when the circumstances would minimize that or maximize it. We certainly know that there have been several studies over the years, so-called randomized clinical trials, in which women of similar backgrounds and similar disease characteristics were entered into a study and randomly assigned to treatment. And there are 3 large trials that present us with information about the addition of radiation therapy to lumpectomy. These are studies that were done in the United States by one of the National Cancer Institute sponsored groups, the excuse me, the NSABP, which accrued 818 patients. There was a large Swedish study of 1,000 patients and a European study of 1,000 patients. And each of these studies gave us very useful information, and they showed the same thing. As you can see in the bar chart, if we look at the percentage of ipsilateral or same-side breast tumor recurrence, we see that radiation therapy reduces the risk, which in the absence of radiation runs anywhere from about 13 to 18%. It reduces that risk approximately by half. Of course, that's quite appealing, and it's one of the reasons that radiation is used. Certainly, having a recurrence risk that is less than 10% has been considered an acceptable and reasonable risk as a trade-off for saving the breast. But interestingly enough, if we look at the next slide, what we are perhaps most concerned about is the issue of not recurring DCIS or non-invasive, non-life-threatening disease. Our real concern is that these studies show that about half the time when a recurrence occurs, it is in fact an invasive recurrence. That is, it is disease that now has come back as a potential life threat. Radiation can reduce this risk itself again by half or more, but again, what this shows us is that DCIS at the front end is no threat. But at the back end, if there is recurrence, that recurrence may be invasive, and reducing that risk of invasive recurrence is quite important. Of course, we do need to pay attention to the fact that no matter how these patients were treated on the front end of the study, whether it was lumpectomy alone or lumpectomy with radiation, even recognizing that half of the recurrences were invasive disease, and even recognizing that radiation therapy can reduce that risk by about half, still, overall, in the follow-up of these studies, there was no difference in survival. Now, that doesn't mean that individual women who recurred with invasive disease may not have had a disease that went on to metastasize and spread to other parts of the body, and that an individual may not have died, but simply that that death was balanced out by another death for other reasons, perhaps in the other arm, suggesting that the numbers aren't high, although they could be real. So I don't think anyone would suggest that we should take a very, very blithe and uncaring approach to this issue, only that we need to keep in mind that this isn't the major issue. Again, our endpoint is minimizing recurrence, and certainly no one wants to have a recurrence of invasive disease where the treatment may include mastectomy, chemotherapy, and much more aggressive therapy that is difficult, painful, or unpleasant to go through. What about the prognosis and recurrence risk? Well, it turns out that the prognosis for most women with DCIS is excellent. Only a small percentage experience a local recurrence, whether it's DCIS or invasive disease. What we'd like to do is determine which patients are at high risk and think about how we might optimize treatment and avoid overtreatment of these individuals. Of course, there are additional treatments that can be added to our surgical intervention. These include radiation therapy, as we've discussed, and we've shown you the rationale for that, as well as hormonal therapy, which we haven't discussed. There are a number of traditional measures for assessing risk, and these come down generally to age, the amount of residual tumor, or in fact, if there is residual tumor, or the width of the margins or clear tissue around a resection, the so-called grade or aggressive appearance of the tumor, the histology, meaning the architectural shape of the tumor, its size, and its menopausal status. Several of these, unfortunately, however, are based on subjective opinion. And what looks like a high-grade tumor to one pathologist may not look so high-grade to another. One histology may differ in one pathologist's hands versus in another's, or by which part of a specimen the pathologist even looks at. So it would certainly be valuable to have a less subjective and a more objective way of determining the risk of any DCIS. A recent clinical study demonstrated that a genomic assay, one that looks at what genes are turned on and turned off in a cell, called Oncotype DX, can be used to determine recurrence risk based on the intrinsic tumor biology. The DCIS score was, of course, developed from a series of correlative science studies. And these studies actually compared gene expression on invasive cancer and DCIS, and they analyzed both local and distant recurrence risk in invasive disease and, of course, local risk in DCIS. A number of genes that predict local recurrence were selected, and these were similar in invasive and non-invasive or DCIS disease. But in fact, it turns out that the proliferation genes were the most important, the genes that related to growth, and so ultimately 7 cancer genes and 5 so-called housekeeping genes that are always turned on that can be used to standardize assays from one run to another were selected for this particular assay. And what's most important was that after this test was developed in a series of patients that were available for evaluation, the test was not tested itself or validated in this group of patients, but in a totally separate group of patients that had been entered into a National Cancer Institute funded and overseen clinical study. And when that was done, it turns out that you can develop a scoring system that can measure a score against the 10-year risk of recurrence. And we use the term IBE to mean ipsilateral breast event. An event, of course, is either a new cancer or a recurrence of the original cancer. And what you see on this chart on the left-hand panel is that as you move across from left to right, this DCIS score calculated from the developed test or assay goes up. And as that score goes up, the 10-year risk of any event in that same breast goes up as well. The dotted line simply showing the confidence intervals in which 95% of the patients would fall for any given score around the central line. Now, on the right-hand side is perhaps the even more important panel in which we see what the recurrence is for invasive same-side breast events or ipsilateral breast events. And again, you can see as the score increases along the bottom axis from left to right, the 10-year risk goes up. Now, if we divide patients into a low and an intermediate and a high-risk group, as seen by the vertical lines sort of running between 40 and 50, or 38 and 55, you can see that the low-risk group of patients actually do much better if we look at time in years on the bottom against, again, the risk of same-side breast events or ipsilateral breast events. The low risk in blue climbs slowly over time, but you see the red, which is the high-risk group, of which about 27% of patients fall into, actually increases at a much higher rate. And what you can see on the other side is that the risk, I'm sorry, that's not 27% of patients, that's a 27% 10-year risk of recurrence that occurs to those people. And you can see on the invasive breast events on the right-hand panel that the red line, which is again the high-risk group, jumps even faster. So what really becomes very important is that the invasive breast cancer events, which we worry about the most, clearly can be separated from the high-risk group to the lower and intermediate risk group, which is what we would like to do. And if, in fact, we can do that, we may be able to say, well, perhaps these groups of patients who have lower risk disease may not need some additional treatments that are designed to reduce recurrence risk, such as radiation therapy. So the DCIS score was evaluated among these 327 women in a study of women with lumpectomy but not radiation, and 3/4 of the patients turned out to have a low DCIS score. And among these low score patients, the overall likelihood of recurrence was only 12%, and the likelihood of invasive recurrence was only 5%. But in the high-risk group of people, the likelihood of any recurrence, as I said before, with some correction, was 27%, and the likelihood of invasive breast cancer, which we worry about because this is a life threat, was 19%. Now, 75% of low-grade DCIS does express hormone receptor, and about 30% of pathologic, not by oncotype, but by the pathologist's view, high-grade DCIS expresses hormone receptors. There was a large study done by the NSABP, the group we talked about earlier, in women with DCIS in a study who received either tamoxifen, an anti-estrogen hormone drug, or placebo after lumpectomy and radiation therapy. And this showed that recurrence rates were about 8.2% overall in the women who received tamoxifen versus about 13.5% in the patients who received a sugar pill or placebo. And of course, this study included women with hormone receptor positive and negative patients. Initially, that wasn't an entry criteria, but later on, when they went back and looked to see, it turns out that the tamoxifen benefit, the anti-hormone benefit, if you will, was seen only in women, as we might expect, who had hormone receptor positive breast cancer of DCIS. So what we've talked about over time is a way of beginning to think about personalizing this treatment. The treatment for DCIS is we like to personalize the treatment for so many diseases. One of the leading physicians of the last century, one of the great 4 doctors who founded the first modern medical school curriculum at Johns Hopkins University in the early 1900s, was William Osler. He wrote the first major textbook of medicine in the United States, and he stated, variability is the law of life, and as no two faces are the same, so no two bodies are alike. And No two individuals react alike and behave alike under the abnormal conditions which we know as disease. We have, for way too long, treated patients and their diseases as a class and not as individuals. And I think, happily, with modern tools, some of which we've talked about today, we'll be able to move beyond this and personalize and individualize care in the future, particularly for diseases like DCIS. We're going to take a quick break here for a moment, and then we're going to move on to some questions. We'll take some questions and provide answers to those that have been sent in ahead of time, and we'll be happy to take questions from individuals who would like to call those up.